Okay, so we're going to be continuing with the third part for the respiratory system. This is part C. So there's two ways oxygen gets carried in blood. It's either bound to the iron in the hemoglobin within the red blood cells, or is dissolved in blood plasma. Because oxygen is poorly soluble in water, only about 1.5% of the oxygen transported is carried in it. Hemoglobin is made up of 4 polypeptide chains, with each bound to an iron-containing heme group. The iron atoms bind oxygen, so each hemoglobin molecule can combine with 4 molecules of oxygen, and the oxygen loading and unloading takes place rather quickly. When oxygen combines to hemoglobin, we call it oxyhemoglobin. So this is how we denote that, HbO2. Okay. Now, hemoglobin that's been released, that has released oxygen, it gets reduced to just hemoglobin. So that term we use is called deoxyhemoglobin. And we write that, we use this acronym here, double capital H and lowercase b. So oxygen, when it attaches to hemoglobin, it's oxyhemoglobin, and oxygen by itself without the oxygen, deoxyhemoglobin. So again, what we're showing you over here in this equation is that hemoglobin can bind with oxygen, and hemoglobin, and again we call this oxyhemoglobin, and oxyhemoglobin can also be reversed, and when we reverse it, we get deoxyhemoglobin. So if you look over here, we get oxyhemoglobin, plus we end up getting this hydrogen atom over here. So again, this is a reversible reaction, and this takes place rather quickly. We'll see how that happens in this lecture. In terms of the efficiency of loading and unloading oxygen, after the first oxygen molecule binds to the iron, the hemoglobin molecule changes shape. This makes it more easily to take up 2 more oxygen molecules, and the uptake of the 4th is even more easier. So we say a hemoglobin molecule is partially saturated when 1, 2, or 3 oxygen molecules are bound to it. When all 4 of its heme groups are bound to oxygen, we say that the hemoglobin is now fully saturated. And the same mechanism is observed in the reverse process. Unloading of one oxygen molecule makes it easier for the unloading of the next, and on and on and on and so forth. So in this manner, the binding strength of hemoglobin for oxygen changes with the extent of oxygen saturation. So both the loading and unloading of oxygen ends up being very efficient. The rate at which hemoglobin reversibly binds or releases oxygen is affected by factors such as temperature, blood pH, the percentage of dissolved oxygen we have, and also the concentration of a chemical called BPG. And we'll talk a little bit more about this in the next few slides. So the amount of oxygen carried by hemoglobin is dependent upon the blood oxygen saturation levels. So when we look at this graph over here, what it's showing you is that, first of all, the y-axis is showing you the amount of oxygen that's bound to hemoglobin. And this over here, the x-axis, shows the percentage of dissolved oxygen that's found within blood. So this is the partial pressure of oxygen. This is the x-axis. So as you see, as the partial pressure increases, more oxygen starts binding to the hemoglobin molecule. Now, under normal resting conditions, arterial blood hemoglobin is 98% saturated, and 100 milliliters of systemic arterial blood contains about 20 milliliters of oxygen. So as arterial blood flows through systemic capillaries, it releases about 5 milliliters of oxygen per 100 milliliters of blood. So this gives us a hemoglobin saturation of about 75% and an oxygen content of about 15% in venous blood. So what does this mean? This means that we still have quite a bit of oxygen that's still available in venous blood. And we can end up using this later on. So this is what we call the venous reserve. All right, so in this picture over here in this slide, the picture on top, we're looking at oxygen and hemoglobin in lung tissue. And the pictures on the bottom, we're looking at oxygen and hemoglobin in tissues. Okay, so in skeletal muscle, or it could be in the heart muscle, for example, or in your intestines, the cells of the tissue that you have in the intestines. So let's go up over here first. So what they're telling you over here is this. So at sea level, we have a lot more oxygen available. So the partial pressure of oxygen in the lungs, it's about, so let's say, 100 millimeters of mercury, right? So at sea level, we end up getting 98% saturation. Hemoglobin is 98% saturated with oxygen. Now, once we start going up to higher altitudes, so at higher altitudes, there's less oxygen available. Okay? So the partial pressure for oxygen at, let's say, somewhere up high in the mountains, it's going to be about 80 millimeters of mercury. So at that point, oxygen is only 98% saturated. Now, let's come down over here at tissues. So remember, over here, what's happening? We're getting oxygen loading and oxygen unloading. That's taking place in the lungs. Now, in tissue, however, this is where oxygen is being used, right? So we're looking at metabolically active tissue. So again, when at rest, okay, when just laying down, doing nothing, or you're sitting down, the partial pressure is going to be much lower. So what they're showing you over here in this first photograph is that, look, at rest, when we have about 40 millimeters of mercury, when we measure the oxygen around hemoglobin, at that point, 80% of hemoglobin will be saturated, all right? However, when there's less available, so now we're looking at this slide over here, so this is this point, in metabolically active tissue, right? When the partial pressure of oxygen is about 20%, at that point, 40% of hemoglobin is going to be bound to oxygen. Red blood cells produce a chemical compound that metabolizes glucose. It's called BPG, or it stands for 2,3-bisphosglycerate. BPG binds reversibly with hemoglobin, and when oxygen levels are chronically low, BPG levels, they rise. So all these factors influence hemoglobin saturation by modifying hemoglobin's 3D structure. Thereby, it changes its affinity for oxygen. So an increase in temperature, the partial pressure of carbon dioxide or hydrogen ion levels, or even BPG levels in blood lowers hemoglobin's affinity for oxygen, and this enhances oxygen unloading from the blood. So again, what we end up seeing, if we were to map it out or plot it out on a graph, it shows a rightward shift of the oxygen hemoglobin dissociation curve. And of course, if we have the opposite, in other words, we have a decrease in all these factors, we end up seeing a shift in the curve to the left. And again, this decreases oxygen unloading from blood. So in this graph, we're looking at the effects of temperature and oxygen binding. So this is the percentage of oxygen saturation of hemoglobin, and which is the y-axis. And on the x-axis down over here, it's not labeled, but this would represent the partial pressure of oxygen. So again, this is about 20, and again, this would be at the end about 100 over here. So each one of these squares represents about 10 units. So if we start over here, for example, or at this point, let's say this is about 20 and 30, 40, and then this would end up taking us to roughly 100. So essentially what we're looking at, let's go over here. So if this is normal body temperature, which is about 38 degrees centigrade. So at this point, again, everything is nice and optimal. So when we come to over here, again, we get about, let's say about 98%, 94, 92% saturation that takes place at about, when the partial pressure is about, when it's at 100%. Now, when we come over here, as you start to move further away, now let's take a look and see what happens as the temperature drops. So when you have lower temperatures, then this shifts to the left. So we have a left shift. The curve shifts to the left. The dissociation curve. So on the other hand, when the temperature increases, we have a right shift that takes place. So again, things move over to the right at higher body temperatures. So you can see over here at higher body temperatures, this dissociation curve. So if let's just go with that about, I don't know, say for example, so this 20, 30, about 40 millimeters of mercury. Where are we at in terms of saturation? We're at, for higher body temperatures, we're at slightly over 50, maybe 52%. Okay, and at normal body temperatures, at the same amount of the partial pressure is the same, we have, look at that, we have over 70, so about 72%. Okay. However, again, if we come over here now, again at the same point, what ends up happening at lower temperatures? Lower temperature, it's going to be much higher. So again, it's a left shift. The shift takes place to the left. So at that same partial pressure, we have over 90% saturation at 20 degrees centigrade. Now in this next slide, we're going to be looking at increasing carbon dioxide, or again, increasing in the hydrogen ions. So in other words, we're talking about a decrease in pH. So again, when you come over here, so at normal arterial carbon dioxide levels, so again, the partial pressure of carbon dioxide at about 40 millimeters mercury, or again, the pH is roughly 7.4. And again, remember, the range for blood pH is anywhere from 7.35 to 7.45. So we have to stay within this range. So over here, we're saying it's 7.40. So what ends up happening is this. So as carbon dioxide levels increase, okay, or again, the pH decreases. Now we're looking at 7.2. We get a shift to the right. Okay, and again, the opposite will hold true. We get a left shift. Okay, a shift to the left if the carbon dioxide levels decrease. Okay, so again, when we increase, we get a shift to the right, and a decrease causes a shift to the left. So this right shift, we end up having this increase in acidity or increase in carbon dioxide. This right shift that takes place is called the Bohr effect. Okay, Bohr effect. Moving forward, temperature, BPG levels, pH, and carbon dioxide levels are factors that tend to be the highest in systemic capillaries. Again, the goal in systemic capillaries is oxygen unloading. So, as cells metabolize glucose and use oxygen, they release carbon dioxide, which increases the partial pressure of carbon dioxide, and it increases the hydrogen levels, okay, which means more hydrogen levels release, blood pH is lower, blood becomes more acidic. So these levels will start to elevate in capillary blood. All right. So this combined declining blood pH, we use the term acidosis to describe that. Okay, declining blood pH, the increasing partial pressure of carbon dioxide. This is going to weaken the hemoglobin oxygen bond, right? And again, we call this is what I showed you in the previous graph. We use the term Bohr effect, okay, to describe this. Okay, so the Bohr effect essentially enhances oxygen unloading. So one of the byproducts of metabolic activity is heat. So active tissues they're warmer than less active tissues. So again, think about it. When you're sitting and if you palpate, if you feel your body temperature, your skin, it's going to be warm. But when you exercise, and especially, if you feel the areas of the muscles that you've been exercising, it's going to feel much, much, much warmer. It'll feel hot. So a rise in temperature decreases hemoglobin's affinity for oxygen, both directly and indirectly. So collectively, these factors, they allow for hemoglobin to unload much more oxygen in the area of hardworking cells in tissues where the cells are very active, such as skeletal muscle. So this term hypoxia essentially means you're not getting enough oxygen delivered to tissue. And sometimes when this is occurring, in severe cases of hypoxia, you'll start to see an individual's skin start to appear blue. And again, the term that we use to describe that is cyanosis. So cyanosis is, when tissue starts to take on the result of appearing blue. And hypoxia could occur for many reasons, but some of the most common ones we'll go with is something that's called anemic hypoxia. In anemic hypoxia, again, it comes from anemia. There is not enough healthy red blood cells, or again, like as I said, there's not enough red blood cells. Or sometimes what ends up happening is there's not enough hemoglobin that's there. So, it could be abnormal or too little hemoglobin. So this results in anemic hypoxia. Other times there could be ischemic hypoxia. So in ischemic hypoxia, this is hypoxia that results because of a decreased amount of blood flowing to a specific part of the body, to specific tissue. So there could be a blockage. So again, there's some type of a disturbance that's hindering normal flow of blood. So again, we call that ischemia. Anytime we have a narrowing or decreased amount of blood going to tissue, that we use the term ischemia for that. In histotoxic hypoxia, this happens when body cells are not able to use oxygen even though an adequate amount is delivered. So metabolic poisons such as cyanide can cause histotoxic hypoxia. When you look at hypoxemic hypoxia, this usually it's indicated by a reduced arterial blood oxygen levels. So possible causes, it could be disorders or abnormal ventilation or perfusion coupling, pulmonary diseases such that impair ventilation, and also breathing air containing not enough oxygen. Okay, so like scant amounts of oxygen in the air that you're breathing. This could also result in hypoxia. The last one over here, carbon monoxide poisoning. So this is a unique type of hypoxemic hypoxia. In that, again, this, you're taking in too much carbon dioxide. You're breathing in higher amounts of carbon dioxide than you are of oxygen. And I'm sorry, not carbon dioxide, carbon monoxide. You're taking in too much carbon monoxide, which you should not be taking in at all, instead of oxygen. So the amount of oxygen is less and carbon monoxide is greater. And unfortunately, carbon monoxide can bind with hemoglobin 200 times better than oxygen does. So instead of binding oxygen, hemoglobin is going to pick up that carbon monoxide. And, we can't use carbon monoxide, so we end up getting poisoning and you die. Normally active body cells produce about 200 milliliters of carbon dioxide every minute. And this is the same amount that's excreted by the lungs. So our blood is able to transport carbon dioxide from the tissues to the lungs in 3 ways. Okay? Either in dissolved plasma, okay, which accounts for about 7 to 10%, or it's chemically bound to hemoglobin, and again we call this carbaminohemoglobin, okay, and this accounts for about, again, 20%. And lastly, as bicarbonate ions, okay, which accounts for about 70%. So when dissolved carbon dioxide diffuses into red blood cells, it combines with water, forming carbonic acid. Okay, so carbonic acid is unstable and dissociates into hydrogen ions and bicarbonate ions. All right, so when we look at this equation up over here, carbon dioxide and water forms carbonic acid. Carbonic acid can turn into or dissociates into hydrogen and bicarbonate. And again, this is reversible. So bicarbonate and hydrogen can turn into carbonic acid, and carbonic acid can then dissociate into carbon dioxide and water. So while this reaction also occurs in plasma, it's 1,000 times faster in red blood cells because red blood cells contain an enzyme called carbonic anhydrase. And carbonic anhydrase can reversibly catalyze the conversion of carbon dioxide and water to carbonic acid. So hydrogen ions released during the reaction bind to hemoglobin, and this triggers the Bohr effect. Okay. So once bicarbonate is generated, it moves quickly from the red blood cells into the plasma, and from there it's carried to the lungs. Now, to counterbalance the outflux of these anions from the red blood cells, chloride ions move from the plasma into the red blood cells. This ion exchange process is what we call the chloride shift, and it occurs via facilitated diffusion through the red blood cells' membrane proteins. So in this picture over here, what are we seeing? We're looking at tissues. It could be any time, let's say skeletal muscle tissue, for example. So it's releasing carbon dioxide. Well, the carbon dioxide is in the interstitial fluid, and then the red blood cell comes along, and some of that carbon dioxide will stay in the tissue. And the carbon dioxide that stays in the tissue, okay, no problem, combines with water, and then slowly it gets converted into carbonic acid, and that carbonic acid then gets converted into bicarbonate and hydrogen. Okay, so the other thing that can happen, so again, the main thing about this is that this process is occurring slow. Now, the other thing that will happen is that the carbon dioxide gets picked up by the red blood cells. Okay, so it goes into the red blood cell, and in the red blood cell, this carbon dioxide and water then reacts with carbonic anhydrase, and very quickly it ends up being converted into carbonic acid. Okay, so the carbon dioxide and water come together inside the red blood cell. Carbonic anhydrase, I think I said carbonic acid earlier. Carbonic anhydrase, this enzyme, will quickly convert carbon dioxide and water to carbonic acid. So then the carbonic acid will then dissociate into bicarbonate and hydrogen. Bicarbonate is going to go out, and the hydrogen, it's going to end up binding with a hemoglobin. Now you get deoxyhemoglobin. Chloride ions, they come inside the red blood cells. Okay, so these are two ways that we get this transport of carbon dioxide. One way is slow, the other is very fast. So now in the lungs, the process is reversed. So as blood moves through the pulmonary capillaries, the dissolved plasma carbon dioxide, it declines from about 45 millimeters of mercury to about 40 millimeters of mercury. Now, in order for this to occur, the carbon dioxide, first, it needs to be freed from the bicarbonate. So bicarbonate re-enters the red blood cells, and the chlorides, they move out back into the plasma. Okay? Next, bicarbonate binds with a hydrogen ion to form carbonic acid. Then the enzyme carbonic anhydrase splits the carbonic acid to release the carbon dioxide and water. The carbon dioxide then diffuses along its partial pressure gradient from blood into the alveoli. So in this photograph over here, in this drawing, we have an alveolus and we've got gas exchange taking place. So we have oxygen moving in. As oxygen enters the red blood cell, it combines with carbaminohemoglobin and it forms oxyhemoglobin. And we end up getting a hydrogen that ends up going and it combines with bicarbonate. So some of the bicarbonate, okay, that's there, ends up turning into carbonic acid. Now, that carbonic acid reacts with carbonic anhydrase and we end up getting water and carbon dioxide. And then this carbon dioxide then diffuses out with this partial pressure gradient into the alveolus. Now, when we go outside the red blood cell, so we have, again, our bicarbonate and we have a hydrogen ion. It forms carbonic acid. So slowly, the carbonic acid then dissociates into water and carbon dioxide. So again, this process happens much slower than it does inside the red blood cell because, again, inside the red blood cell, there's carbonic anhydrase that speeds up the conversion, the dissociation of carbonic acid into carbon dioxide and water. The amount of carbon dioxide blood can transport is affected by the amount of blood is oxygenated. The lower the partial pressure of oxygen and the lower the hemoglobin saturation with oxygen, the more carbon dioxide that blood can carry. We term this to be the Haldane effect, and it reflects the greater ability of reduced hemoglobin to form carbaminohemoglobin and to buffer the hydrogen ions by combining with it. As carbon dioxide from tissue enters the systemic bloodstream, it causes more oxygen to dissociate from hemoglobin. And again, this is what's known to be the Bohr effect. Okay? When you look at the Haldane effect, this is the dissociation of oxygen, which allows more carbon dioxide to combine with hemoglobin. The bicarbonate generated in red blood cells diffuses into plasma, where it acts as an alkaline reserve, which is part of the blood's bicarbonate buffer system. Now, this system is very important in resisting shifts in blood pH. So, if we have hydrogen ion concentrations in blood that start to rise, the excess hydrogen ions, they get removed by combining with the bicarbonate to form carbonic acid. Then the carbonic acid gets metabolized to carbon dioxide and water. Now, if the hydrogen ion concentration in blood drop below normal levels, then the carbonic acid dissociates, releasing the hydrogen ions, and again, it ends up lowering the blood pH. Changes in respiratory rate or depth can significantly alter blood pH. So, shallow breathing allows carbon dioxide to accumulate in blood. This results in carbonic acid levels to increase and blood pH levels to drop. Conversely, rapid, deep breathing quickly removes carbon dioxide out of the blood, which reduces carbonic acid levels and increases blood pH. So, respiratory ventilation provides a fast-acting system to adjust blood pH when it's disturbed by metabolic factors. Aside from that, respiratory adjustments, they play a major role in just maintaining the overall acid-base balance of your blood. The control of respiration primarily involves neurons from the reticular formation of the medulla and pons. The medulla sets the respiratory rhythm. Now, we find neuron clusters in two areas of the medulla that appear to be critically important in respiration. And these two areas are the ventral respiratory group and the dorsal respiratory group. We use the acronym VRG and DRG also to describe these two. So the first one, we'll talk about both these a little bit later, but just before we get to there, the dorsal respiratory group, we find this located dorsally near the root of cranial nerve number 9. And as for the VRG, these networks, it's a network of neurons, and so it extends from the ventral brain stem, from the spinal cord, to the pons medulla junction. So the ventral respiratory group, the VRG, it appears to be a rhythm generating and integrative center. So it contains groups of neurons that fire during inspiration and others that fire during expiration. So when its inspiratory neurons fire, impulses, they travel from the phrenic and intercostal nerves to excite the diaphragm and the external intercostal muscles. The thorax expands and air rushes into the lungs. And when the VRG's expiratory neurons fire, the output stops, inspiratory muscles relax, and the lung recoils, and expiration occurs. So this term over here, eupenia is just normal. It's the normal respiratory rate and normal respiratory rhythm. So again, ideally, if you kind of work the math out, this number should fall between 12 to 15 breaths per minute. In reality, the range clinically, if you're to look at, what do you call eupenia? So again, when this number is anywhere from 12 to 20 breaths per minute, you're within range of what could be normal breathing or good breathing. You have bradypnea. So when the rate falls below 12 breaths per minute, we call that bradypnea. And tachypnea, that's when you have respirations or breathing occurring greater than 20 breaths per minute. So eupenia, bradypnea, and tachypnea. These are 3 terms you may want to be familiar with. The dorsal respiratory group integrates input from peripheral stretch and chemoreceptors and communicates that information to the ventral respiratory group. So as mentioned earlier, the DRG is located dorsally near the root of cranial nerve number 9. And there's still a lot that they don't know about this part of the brain, this area of the brain. So again, as much as science knows, everything is not known, and especially when it comes to brain. The brain, it's understood, but again, it's not very well understood. There's still a very large area that we don't understand very well. The pontine respiratory centers influence and modify the activity of medullary neurons. The pontine center appears to smooth out the transition from inspiration to expiration, and vice versa. Along with other pontine centers, the pontine respiratory group transmits impulses to the ventral respiratory group of the medulla. And this input modifies and fine-tunes breathing rhythms, which are generated by the ventral respiratory group during activities like sleeping, vocalization, and exercise. So in this photograph over here, in this drawing here, this illustration, we're looking at the brain stem, and we're looking at this part, and down here, this part going down, this is the medulla oblongata, and then as we go above, this is the pons. So let's start off top and then we'll work our way down. So within the pons, the area of interest is this part over here. This is the pontine respiratory center. So below that, in the medulla, we have our ventral and dorsal respiratory group. And what they're trying to show you over here is that, again, as signals are fired off, we have some signals that end up going to the diaphragm, the phrenic nerve, and then also you end up having the signals that go to some of our muscles that help us breathe, the external and intercostal muscles. So these, as the signals go out, they cause excitation or inhibitory signals. And again, what's going to end up happening is we breathe, and again, other signals they'll help with. So inhale and exhale. Inspiratory depth is determined by how actively the respiratory center stimulates the motor neurons serving the respiratory muscles. The greater the stimulation, the greater the number of motor units excited, then the greater the force of the muscle contractions. The respiratory rate is determined by how long the inspiratory center is active and how quickly it's shut off. So changing body demands can modify both depth and the rate of breathing. So the respiratory center can be affected by changes in chemical factors, influences of higher brain centers, pulmonary irritant reflexes, as well as inflation reflexes. And we'll be looking at some of these as we move through the rest of the lecture. Amongst all the factors that influence breathing rate and depth, the most important are changing levels of carbon dioxide, oxygen, and hydrogen levels in arterial blood. In our body, we have sensors that monitor these chemical fluctuations, which are called chemoreceptors. And we find chemoreceptors in two major body locations. Throughout the brainstem and the ventrolateral medulla, we find central chemoreceptors. And in the aortic arch and carotid arteries, we have the peripheral chemoreceptors. Of all the chemicals that influence respiration, carbon dioxide is the most potent and closely controlled one. As carbon dioxide levels rise in the blood, which is a medical condition that we call hypercapnia, carbon dioxide accumulates in the brain. As carbon dioxide accumulates, it's hydrated to form carbonic acid. The acid dissociates, hydrogen is liberated, and the pH drops. This is the same mechanism I described earlier that occurs when carbon dioxide enters red blood cells. So the resulting increase in hydrogen ions excite the central chemoreceptors of the brainstem, which synapse with the respiratory regulatory centers, and in return, the depth and rate of breathing increases. So the resulting enhanced alveolar ventilation quickly flushes carbon dioxide out of the blood. This in turn raises blood pH back to its normal levels. Now, an elevation of only 5 millimeters of mercury in arterial carbon dioxide doubles alveolar ventilation even when arterial oxygen levels and pH levels haven't changed. When oxygen and pH are below normal, the response to elevated carbon dioxide is even greater. Increased ventilation is normally self-limiting. It ends when homeostatic blood carbon dioxide levels are restored. So, while the rising blood carbon dioxide levels act as an initial stimulus, it's the rising levels of hydrogen ions that are generated within the brain that push the central chemoreceptors into increased activity. When carbon dioxide levels are abnormally low, we essentially have the opposite take place. Respiration gets inhibited, breathing becomes slow and shallow, and this continues until the partial pressure of carbon dioxide and pH decrease. So essentially what we're looking at over here in this illustration is that changes in carbon dioxide regulate ventilation by the negative feedback mechanism. So higher carbon dioxide increases the depth and rate of breathing, while low carbon dioxide pH rises to abnormally high levels. In this case over here, what we have is high arterial carbon dioxide levels. When chemoreceptors in the carotid and the aortic bodies, when they sense that, again, they send a signal to the medullary center of the respiratory center of the medulla, and then those impulses, they send a signal out to the respiratory muscles. We increase ventilation, more carbon dioxide gets exhaled, and carbon dioxide levels, they go back to normal. Or in the other side over here, now this increased carbon dioxide, it decreases pH. Okay, so now blood's getting acidic. And again, so what happens? We have the central chemoreceptors, right? They're the ones that are sensitive to the hydrogen ion concentration levels. So they end up sending a signal also to the medullary respiratory centers. And again, they send a signal out to the respiratory muscles. Ventilation increases. Everything goes back to normal. And again, everybody's happy. The peripheral chemoreceptors found in the aortic bodies of the aortic arc and in the carotid bodies at the bifurcation of the common carotid arteries contain cells sensitive to arterial oxygen levels. Declining oxygen levels has a slight effect on ventilation that's mostly limited to enhancing the sensitivity of peripheral receptors to increased dissolved carbon dioxide. Arterial oxygen levels have to drop substantially to at least 60 millimeters of mercury before oxygen levels become a stimulus for increased ventilation. And in this slide here, it shows us the locations for the peripheral chemoreceptors that we find in these ones over here are found in the aortic bodies this is the arc of the aorta. And also if you go over here, if you follow the common carotid artery, where it bifurcates into the internal and external carotid arteries, we have another congregation of cells. Now, even when carbon dioxide and oxygen levels are normal, changes in arterial pH can still modify the respiratory rate and rhythm. Because hydrogen ions don't cross the blood-brain barrier, the increased ventilation that occurs in response to falling arterial pH ends up being mediated via the peripheral chemoreceptors. A drop in blood pH may reflect carbon dioxide retention, but it may also result from metabolic causes such as an accumulation of lactic acid during exercise or of ketone bodies in patients with poorly managed diabetes. But regardless of the cause, as arterial pH declines, the respiratory system controls attempt to compensate and raise the pH by increasing the respiratory rate and depth to eliminate carbon dioxide and carbonic acid from blood. As I mentioned earlier, rising carbon dioxide levels are the most powerful respiratory stimulant. As carbon dioxide is hydrated in brain tissue, the liberated hydrogen ions act directly on the central chemoreceptors. This causes a reflexive increase in the breathing rate and depth, and the opposite for low carbon dioxide levels, which will depress respiration. Under normal conditions, blood oxygen saturation levels affect breathing only indirectly, and it's done by influencing peripheral chemoreceptor sensitivity to changes in carbon dioxide levels. Low oxygen levels magnify carbon dioxide effects, and high oxygen levels yield the opposite effect. Therefore, high oxygen levels diminish the effectiveness of carbon dioxide stimulation. When arterial oxygen levels fall below 60 millimeters of mercury, it becomes the major stimulus for respiration. This causes the peripheral chemoreceptors to respond reflexively, increasing ventilation. This may lead to an increase in oxygen loading into the blood, but it also causes low blood carbon dioxide levels along with an increase in blood pH, both of which inhibit respiration. Changes in arterial pH due to carbon dioxide retention or metabolic factors act through the peripheral chemoreceptors. The resulting changes in ventilation in turn modify arterial carbon dioxide and pH. But keep in mind, arterial pH does not influence the central chemoreceptors directly. Through the hypothalamus and rest of the limbic system, strong emotions and pain send signals to the respiratory center, which modify the respiratory rate and depth. For example, increased respiratory rate occurs when we are excited, or you get in a cold swimming pool, or you jump into the sea, which is cold, and you gasp. These responses are mediated through the hypothalamus. Even though the brainstem's respiratory center normally regulates breathing involuntarily, we can also exert conscious or voluntary control over the rate and depth of our breathing. We can choose to hold our breath or take an extra deep breath, as we may do when we're about to swim underwater. Now, during voluntary control, the cerebral motor cortex sends signals to the motor neurons that stimulate the respiratory muscles, thereby bypassing the medullary centers. Now, our ability to voluntarily hold our breath is limited. The brainstem's respiratory center automatically reinitiates breathing when blood concentrations of carbon dioxide reaches critical levels. The lungs contain receptors that respond to a very large variety of irritants. When activated, these receptors communicate with the respiratory center via the vagal nerve afferents. So things such as accumulated mucus and inhaled debris such as dust or other particles, or even nauseous fumes, stimulates receptors in the bronchioles, and then this causes reflexive constriction of those air passages. in the trachea or bronchi, the same irritants stimulate a cough, and stimulation in the nasal cavity triggers a sneeze. The visceral pleura and conducting passages in the lungs contain numerous stress receptors that are stimulated when the lungs are inflated. They signal the medullary respiratory centers via the afferent fibers of the vagus nerves by sending inhibitory impulses that end inspiration and allow expiration to occur. And as the lungs recoil, the stress receptors become quiet and inspiration is initiated once again. This reflex is called the inflation reflex or the Hering-Breuer reflex. And it's thought to be more of a protective response to prevent the lungs from being stretched excessively rather than a normal regulatory mechanism. So this illustration just goes to show you that many different types of stimuli are able to stimulate the respiratory centers in the medulla and the pons. So it could be peripheral chemoreceptors, it could be central chemoreceptors, and receptors in muscles and joints, irritants that we spoke about earlier, stress receptors in the lungs, or again, it could be coming from higher brain centers. Okay, so again, your thoughts that you may be experiencing or stimulus to pain, all of these will end up triggering the respiratory centers, and then your breathing gets affected. Respiratory adjustments during exercise are geared to both the intensity and duration of the exercise. Working muscles consume a huge amount of oxygen and produce a very large amount of carbon dioxide. So ventilation can increase 10 to 20 folds during vigorous exercise. And increased ventilation in response to metabolic needs is called hyperpnea. As exercise begins, ventilation increases abruptly, followed by a gradual increase, and then reaches a steady state. When exercise stops, there's a small but abrupt decline in the ventilation rate, followed by a gradual decrease to the pre-exercise value. Although venous levels change, arterial carbon dioxide and oxygen levels remain surprisingly constant during exercise. In fact, carbon dioxide may even fall slightly below normal, and oxygen may rise slightly above because the respiratory adjustments are so efficient. The most widely accepted explanation for the abrupt increase in ventilation that occurs as exercise begins reflects the interaction of three neural factors. First, it's the psychological stimuli, our conscious anticipation of the exercise. Next, it's the simultaneous cortical motor activation of skeletal muscles and the respiratory center. And finally, the excitatory input reaching respiratory centers from proprioceptors in moving muscles, tendons, and joints. So the gradual increase and then plateauing of respiration probably reflect the rate of carbon dioxide delivery to the lungs. In other words, the carbon dioxide flow. The rise in lactic acid levels during exercise results from anaerobic respiration, but it's not a result of inadequate respiratory function. Alveolar ventilation and pulmonary perfusion are well matched during exercise as they are during rest. Remember, hemoglobin remains fully saturated. Rather, this reflects cardiac output limitations or the inability of skeletal muscles to further increase their oxygen consumption. In terms of high altitude, most people live between sea level and an altitude of approximately 2,400 meters, which is about 8,000 feet. At this range, differences in atmospheric pressure aren't great enough to cause healthy people any problems when they spend brief periods in higher altitude areas. However, if you travel quickly from sea levels to elevations above 2,400 meters, where the atmospheric pressure and oxygen saturation levels are lower, your body responds with symptoms of acute mountain sickness. So, you end up seeing things like symptoms such as, or signs such as headaches, shortness of breath, nausea, and dizziness. In severe cases of AMS, lethal pulmonary and cerebral edema may occur. When you move on a long-term basis from sea level to the mountains, your body makes respiratory and hematopoietic adjustments via an adaptive response called acclimatization. So decreases in arterial oxygen saturation levels cause the peripheral chemoreceptors to become more responsive to increases in carbon dioxide. And a substantial decline in oxygen directly stimulates them. As a result, ventilation increases as the brain attempts to restore gas exchange. Increased ventilation also reduces arterial carbon dioxide levels. So the carbon dioxide of individuals living at higher altitudes is typically below 40 millimeters of mercury. This is its value at sea level. So high altitude conditions result in lower than normal hemoglobin saturation levels because less oxygen is available to be loaded. When blood oxygen levels decline, the kidneys produce more erythropoietin. Erythropoietin is a hormone that stimulates bone marrows to produce red blood cells. This part of acclimatization occurs slowly. It provides long-term compensation for living at high altitudes. Looking at COPD, or chronic obstructive pulmonary disease. This is exemplified by chronic emphysema and chronic bronchitis. The key physiological feature is an irreversible decrease in the ability to force air out of the lungs. Other common features they share: more than 80% of patients have a history of smoking. Another thing is dyspnea, or labored breathing. Another term that's used is air hunger. And it gets progressively worse. Coughing and frequent pulmonary infections are also common. And most COPD patients develop respiratory failure manifested by hypoventilation. And again, this is insufficient ventilation in relation to metabolic needs. And this causes them to retain more carbon dioxide. We also see respiratory acidosis and hypoxemia. Emphysema is distinguished by a permanent enlargement of the alveoli along with destruction of the alveolar walls. The lungs lose their elasticity, and this ends up having three important consequences. First is that the accessory muscles must be used to breathe. The victims are exhausted because it costs 15 to 20% of their total body energy supply, compared to healthy individuals who only use 5%. Next, the bronchioles open during inspiration but collapse during expiration. And this traps huge volumes of air in the alveoli. And this hyperinflation leads to development of a permanently expanded, what we call a barrel chest, and it flattens the diaphragm. Therefore, ventilation efficiency ends up being reduced. The last thing is damage to the pulmonary capillaries as the alveolar walls disintegrate, increase the resistance in the pulmonary circuit. This forces the right ventricle to work much, much harder, and over the course of time, that right ventricle becomes enlarged. So, when you have this occur, it's called right ventricular hypertrophy. Non-chronic bronchitis. Inhaled irritants lead to chronic production of excessive mucus. The mucosae of the lower respiratory passageways become inflamed and fibrosed. This obstructs the airways, severely limiting lung ventilation and gas exchange. Pulmonary infections are frequent in these chronic bronchitis patients because bacteria thrive in the stagnant pools of mucus. Again, smoking is a major risk factor. Environmental pollution also promotes chronic bronchitis. In a clinical setting, you might see two very different patterns that represent the extremes of patients with COPD. One pattern has traditionally been called the pink puffers. These patients work hard to maintain adequate ventilation, that they end up losing weight, becoming thin, but they still have a nearly normal blood gas levels. Okay? Compare that to blue bloaters. Blue bloaters are commonly of stocky build, and they become sufficiently hypoxic, which is why they appear cyanotic. The hypoxia causes constriction of pulmonary blood vessels, leading to pulmonary hypertension and, again, right-sided heart failure. Again, this is what I said before, right ventricular hypertrophy. COPD is routinely treated with inhaled bronchodilators and corticosteroids. Severe dyspnea and hypoxia mandate the use of oxygen, but oxygen must be administered with care. In some of these patients, giving pure oxygen can increase the blood carbon dioxide levels. And again, this ends up lowering blood pH to life-threatening levels. So the solution is to use the minimum concentration of oxygen that relieves the patient's hypoxia. So when we look at the pathogenesis of COPD, so again, living in a very polluted city, for example, or again, working in very polluted environments, such as maybe working in a coal mine. Or again, if you're a smoker, especially heavy smokers, or just having alpha-1 antitrypsin deficiency, well, can go one of two ways. Again, one of the ways is it starts breaking down elastin in the connective tissue of lungs, and then again, what ends up happening, you end up with emphysema. The alveolar walls start to get destroyed, your lungs start to lose elasticity, and this leads to actually both of these things. Let's just go over here and then we'll continue with this way. So the other cause, the other thing that would happen, again, if you're smoking cigarettes and again, air pollution, you can also come down this way. You have long-term or continual bronchial irritation and inflammation, which ends up being chronic. Again, this ends up leading to chronic bronchitis. And in this, your body produces too much mucus. And you also have a chronic cough, a productive cough. And essentially what's happening is, again, the airway obstruction, because all this mucus is just kind of sitting over there, it's blocking the airway. So again, that's your airway obstruction. The air is getting trapped. You have difficulty breathing, you end up getting infections quite frequently, and so what do you end up doing? You hypoventilate, you end up having hypoxemia, and also this could lead to respiratory acidosis. When we look at asthma is characterized by episodes of coughing, dyspnea, wheezing, and chest tightness. You can see this in combination with one another, or you may see individual symptoms. A sense of panic accompanies most acute attacks. Sometimes it's classified with COPD because it's an obstructive disorder. And asthma is marked by acute episodes followed by symptom-free periods. Initially, it was thought as a consequence of bronchospasms triggered by factors such as cold air, exercise, or allergens. Later, researchers found that in allergic asthma, active inflammation of the airways comes first. The inflammation is an immune response controlled by a subset of T lymphocytes that stimulate the production of IgE antibodies that recruit inflammatory cells to the site. Once the airway walls are thickened with inflammatory exudate, the effect of bronchospasm is vastly magnified and can dramatically reduce airflow. Moving on to tuberculosis. So TB is the infectious disease that's caused by the bacterium, Mycobacterium tuberculosis, and it's spread by coughing and primarily enters the body in inhaled air. TB mostly affects the lungs but can spread through the lymphatics to other organs as well. Now, about a third of the world's population is infected, but most people never develop active TB because a massive inflammatory and immune response usually contains the primary infection in fibrous or calcified nodules in the lungs. Unfortunately, the bacteria survive in the nodules, and when the person's immunity is weakened, they may break out and cause symptomatic TB. So these symptoms, they include fever, night sweats, weight loss, a racking cough, and in addition to that, we also see sometimes something called hemoptysis, or coughing up blood. The treatment for this is using antibiotics for about a year. However, deadly strains of drug-resistant, even multi-drug resistant TB can develop when the treatment is incomplete or inadequate. And resistant strains, they're found in certain parts of the world more than other parts. Even as much as in the United States, we're starting to see certain resistant strains now. Lung cancer is the leading cause of cancer and death for both men and women throughout the world, specifically in North America. It kills more people every year than breast cancer, prostate cancer, and colorectal cancer combined. It's a tragic thing because lung cancer it's largely preventable. Why? Because again, 90% of all the cases they come from smokers. So if you don't smoke cigarettes, if you can stop that, then you're going to be significantly decreasing your chance of lung cancer. So the three most common types of lung cancer are adenocarcinoma, squamous cell carcinoma, and small cell carcinoma. Adenocarcinoma, which accounts for about 40% of cases, originates in peripheral lung areas as solitary nodules that develop from bronchial glands and alveolar cells. In squamous cell carcinoma, again, this accounts for between 20 to 40% of cases. This arises in the epithelium of the bronchi or their larger subdivisions and tends to form masses that may bleed. Moving on to small cell carcinomas. Small cell carcinomas account for about 15%, maybe perhaps 20% of cases, and they show round lymphocyte-sized cells that originate in the main bronchi and grow aggressively in small clusters within the mediastinum. Metastasis from the mediastinum is especially rapid. Some small cell carcinomas cause additional problems because they produce certain hormones. For example, some secrete antidiuretic hormone, resulting in the syndrome of inappropriate ADH secretion. Because lung cancer metastasizes aggressively and early, the key to survival is early detection. If the cancer has not metastasized before it's discovered, complete removal of the diseased lung has a greater potential for prolonging life and providing a cure. With metastatic lung cancer, radiation therapy and chemotherapy are the only option, but these have a low success rate. There are new therapies on the horizon, but unfortunately at this point we're pretty much limited to surgery, chemo, and radiation. So that's it for this lecture. Thank you so much for watching, and if you have any questions, please feel free to email me.